A 22-year-old man presented with no prior history of nasal trauma and progressive nasal asymmetry that has been present since childhood. On physical examination, there was firm non-tender asymmetry of the bony vault that did not trans-illuminate on exam. The patient reported obstructive airflow symptoms as well, and intranasal exam revealed septal deviation, but there was no external valve collapse, and a caudal maneuver bilaterally did not elicit any improvement. CT scan showed overgrowth of the nasal bones, resulting in asymmetry of the bony vault. So the problem list for this 22-year-old patient includes non-traumatic nasal deviation, asymmetric overgrowth of the nasal bones, and obstructive airflow symptoms. How would you face the case? Option A, open septorhinoplasty with medial osteotomies and lateral low to high osteotomies. Option B, open septorhinoplasty with medial osteotomies and lateral asymmetric low to low osteotomies with oblique and transverse radix osteotomies.
The votes are in, and you chose A.
Thank you for the interesting case presentation, Dr. Ramly. The degree of asymmetry in this patient clearly means that an open approach is indicated. What I would do is an open septorhinoplasty with asymmetric rasping of the dorsum as well as osteotomies. I usually do an oblique type osteotomy, but whatever type of osteotomy you feel comfortable with is certainly the best approach. In addition to addressing the dorsum and middle vault, however, it's also important to think about other areas that are contributing to the illusion that the dorsum is actually more prominent than it is. What I mean by that is when you look at this patient's photos, you can also see the degree of deformity present in the tip, as well as in the nasofrontal region, as well as over the left medial canthus. When you augment the tip and the nasofrontal region, you are masking the height of the dorsum, meaning that you can make the dorsum feel a little less prominent than it actually is. So these are adjunct maneuvers that can help you create the overall illusion of normal anatomy, when in reality, the anatomy is very clearly distorted from the get-go. Finally, with regards to the medial canthus, we don't really have a way of predictably fixing the medial canthal region, particularly as it relates to that bony soft tissue interaction. However, it is important to address in this patient because it will give you a much more natural and symmetric result. Congratulations to the authors on their result, and please keep following PRS Go for more videos like this. Thank you.